Assalamu alaikum. I would like to share with you our experience in treatment of perthes disease, which, as you already know, there are so many techniques have been described to treat perthes disease in children, but most of them either not logic or didn't prove to be effective or to help the kids and the patients. And we already published our experience in with our technique, which is very different from the common techniques have been used for a very long time in treatment of Behçet's disease. And I will present to you our long-term experience, our rationale, and we have been following our patients for maybe about 11 years or 12 years, and most of them reach already skeletal maturity. And there's main differences between our technique in assessment and in planning and in treatment and execution of treatment that are very different from the other described technique. And I will let you know how we do it. And as I already showed you, this paper is already published and you'll find it on the internet and on PubMed about our midterm results of subtrochanteric valgus osteotomy and symptomatic late presentation of perthes disease. In these patients, we do CT scan. MRI has no use in such cases because you already know the patient has a AVN and this AVN improved, and now we are treating the late consequences of the temporary cut of blood supply. You are dealing with the problem of head deformity, not the problem of trying to revascularize the head. The head is already revascularized, and the deformity happens after revascularization. So it is not an issue that you need to bring blood supply to the head because the head is already revascularized. And after revascularization, it went into collapse and deformation. So we use CT scan to see three-dimensionally the deformity of the head, not counting only on plain X-ray. The other thing is we count on hip arthrography because, as you already know, a major issue here is the surface of the cartilage, not the calcified thing. So the cartilage, you need to see the real surface and where the osteophyte is. So you will be able to bring the osteophyte away from the friction, not to push it inside the acetabulum as some theories claim that they do varus osteotomy to contain the head with the osteophyte and push it inside the hip, which doesn't make sense. And as you see, for example, this is from our paper that this patient and we did the valgus osteotomy, brought the osteophyte away from the friction inside the acetabulum, and we corrected the limb length discrepancy, and we corrected the varus deformity. So the patient now got treated from the Trendelenburg gait and weak abductor and the limb length discrepancy, and there is no friction anymore inside the acetabulum. And here's the follow-up, and as you see, after skeletal maturity, the head is totally spherical and completely healthy. So the children live happily with no deformity, walk normal, and no arthritis. And as I told you, there are so many examples you will see in our talk today. So what's the problem with this AVN or perthes disease in children? The kids complain about stiffness, limited range of movement because of the friction between the osteophyte and the cup of the acetabulum, shortening because of the varus and the collapse of the head, flexion or adduction deformity, abnormal gait, pelvic obliquity, back pain, knee pain. So if we think about the hip, we need the hip to function properly, and to function properly, you need a spherical head. You need a smooth head inside the acetabulum, not to bring the osteophyte, which is a irregular part inside the acetabulum. Unfortunately, the issues that so many doctors say that In perthes disease, the patient eventually will need a total hip at some point. So just leave him or leave her alone, and she will get or he will get total hip at young age. As you already know, there are so many complications from arthroplasty in young age. Not only the short survival, but also the huge limitations that you instruct the patient not to do things, not to avoid things to do, and so many problems with arthroplasty in young patients. So if we can achieve longer life for this hip without using arthroplasty with limited lifespan, that would be great. So we need evidence-based medicine. Evidence-based medicine consider what the patient need, not only what the surgeon know. So let us have a look at deformities of the imperthes disease. Some would say there is coxa magna. Coxa magna is a plain X-ray definition and has nothing to do with reality. Coxa magna is seen in perthes and also seen in after AVN and also seen after DDH surgery, but it does not affect the patient life. What the patient really suffer from in cases of perthes disease is the abnormal gait and the pain and the shortening and the pelvic obliquity. As you already know, before age of 6, the child is still growing. So there is enough time for remodeling during the growth. So most of these kids need no surgical treatment because they get spontaneously improved by time. In follow-up 3 to 5 years, the head gets spherical again, totally normal. But after the age of 8, the residual time between the deformation and the skeletal maturity is short and not enough for the head to get spherical again. So in age less than 6, we recommend no surgery, just follow up, and the child will get normal within 3 to 5 years without anything. And unfortunately, we get so many papers about perthes disease. They do surgery for whatever reason, and most of the population they treated were less than 6, which make no sense because they will already get better even if they didn't get the surgery, and they claim that they got better because of the surgical intervention. But after age of 8, as I was saying, the deformation will not have enough time for remodeling to get improved and get better. So the patient get left with residual limb length discrepancy and varus at the hip and limited abduction and Trendelenburg or abductor insufficiency and pelvic obliquity. This is the issue, and the patient live with this for a very long time, suffering from back pain and hip pain, not because of the hip arthritis, but because of the limb length discrepancy and the varus of the hip and the abductor insufficiency. So for example, see this study talking about conservative treatment. And if you look inside the study, most of the kids included were younger than age of 8. So they get it better anyway. So that's the point. What's the point in talking about either this technique or that technique in young kids like these? Another thing that there is this myth talking about if the patient has perthes disease, eventually he will get early osteoarthritis of the hip anyway, and this arthritis will need total hip at some point. But let me tell you, osteoarthritis of the hip in perthes disease, according to literature, show up at age of 50 in most of the cases. Some patients get some hip pain because of the limb length discrepancy and pelvic obliquity and Trendelenburg, not because of the arthritis, but because of the limb length discrepancy and pelvic obliquity and varus hip. But they go to a surgeon, he or she look at the x-ray and, oh, you have old perthes disease. Let me do a total hip for you to make you better and get a normal bone out without any arthritis or very minor arthritis of the hip and put an artificial joint there. What we do is basically we do hip arthrography and define where the osteophyte is and correct the limb length discrepancy and the varus by valgus osteotomy. And we rotate the head. So we bring the osteophyte wherever it is away from the labrum and the acetabulum. So basically, we do what we already know from femoral acetabulum impingement, that you need to bring the osteophyte away from the range of the hip movement, not inside. We do not have any solid evidence to prove any kind of osteotomy we already have. So let me see. Here's the natural history of perthes disease. It starts like this, and after few years, it gets this shape. So here, what we should do, should we do a total hip? Unfortunately, some people do that. They tell the patient, wait for a few more years till skeletal maturity, and then we take this smooth, normal head and put an artificial joint instead of doing pelvic osteotomy or femoral osteotomy. I would like to remind you again, we learned from femoral acetabulum impingement theories that if this osteophyte or this prominence in cam deformity or pincer, should we bring this inside the acetabulum or away from the acetabulum? Should we remove this or we keep this? We remove this. We bring this away from the range of movement, not inside. It is exactly the same thing in osteotomies, like osteotomies of the knee. You redistribute the load. You relieve the load from the diseased area and bring it more on the healthy cartilage. The main concept behind many surgeries that we hear about in treatment of perthes disease is what they call containment. They propose a theory that if we force this deformed head inside the acetabulum, eventually it will get remodeled and take the shape of this acetabulum, which doesn't make sense. This containment either by abduction brace, which is useless and just make the patient suffer from stiffness and stuff like that, or by pushing the head inside by whatever technique. Our findings suggest that acetabular coverage appears to have little, if any, association with the likelihood of collapse in patients with AVN. We found a small association between a lower LCEA and higher odds of collapse. This is a paper that was published that if there is an association between femoral head collapse and acetabular coverage, and they found no, there is no association. So the concept of containment or forcing a deformed head inside the acetabulum actually doesn't make sense and it doesn't work. On the other hand, this patient came to you because he has varus. So if you do a varus osteotomy, you're increasing the deformity, you're increasing the limb length discrepancy, you're increasing the Trendelenburg gait. For whatever, what is the rationale? You are just behind a theory, say that containment will make the head better, which doesn't make sense, as I was explaining. So varus osteotomy doesn't make sense. Also, pelvic osteotomy. If you are telling me that I will do pelvic osteotomy to contain this head with this osteophyte inside the acetabulum, that will create arthritis, that will create friction and more pain for this patient, not less pain. So containment in perthes disease didn't prove to work. So why some surgeons found it worked? Because they did it for the wrong indication. They did it for patients without osteophyte, with smooth head. So they contained a head that didn't need containment. So this is another paper, a long-term study of alignment correction following proximal femoral varus osteotomy and Pemberton osteotomy. And what they found, the same issue. So they found that they contained a head that didn't need to be contained. Another technique that was described is hip distraction, that they say we will distract the hip and get this head inside the acetabulum and it will remodel. And unfortunately, it failed. And these patients, most of these patients ended out with stiff hip because, as I was saying, containing this hinge, this osteophyte inside the acetabulum doesn't work. Doesn't work technically, doesn't work logically. Cast also doesn't work. As I explained, varus and pelvic osteotomy doesn't work. Adductor tenotomy, useless. Why to do an adductor tenotomy? They say just to relieve the hip. It's just doing the wrong surgery in the wrong place for just because you don't know what to do else. And arthrodiastasis or hip distraction. So none of these techniques proved to improve the sphericity of the head. And also, it didn't show any effective long-term outcome. So you make the patient suffer today, and you don't have really the promise that this patient will be better in the future. So what we say that we didn't depend on the classic classifications of perthes disease because classification, either Salter and Thompson or lateral pair or cateral classification, all these classifications are dependent on X-ray, which doesn't show the cartilage and the surface of the hip. On the other hand, it shows the stages, but not the severity. We count on Stilberg classification, which is mainly either spherical and congruent, or aspherical and congruent, or aspherical and incongruent. How to do this classification? By hip arthrography. So we know exactly where's the diseased side, where's the osteophyte, and we bring this osteophyte away from the flexion of the acetabulum, not force it inside the acetabulum. So in aspherical and congruent, we do valgus and rotation osteotomy, and aspherical and incongruent, we do also valgus and rotation osteotomy to bring the friction away from the acetabulum and correct the varus deformity and the limb length discrepancy. While in spherical and congruent, they need no treatment. So here's an example. And here's after surgery and after putting the valgus and rotation osteotomy. We have so many cases, and as you see, we have very long follow-up, and all these patients now are living normally. As you see here, this is a 15 years follow-up, spherical head. This is the site where the osteotomy was. The patient is doing everything, playing football, doing everything, and the head is spherical. And this is also the MRI, the 15-year follow-up MRI. So we shouldn't count on things that are not related to the symptoms or the anatomy of the patient. Also, head at risk signs. Head at risk signs have very poor inter and intra observer reliability. So, head at risk signs has nothing to do with indication. If the patient is older than 8 years old, if the patient is female, if you get signs that showing osteophyte and hinge abduction, this is a patient who need treatment. But in younger than 6 years old, don't do anything. Just leave the patient alone and he will get better. Look at this picture. This is where the osteophyte is. So if you have this osteophyte, would you force it inside the acetabulum, as some people claim, or bring it away and correct the varus deformity? This is how we should think, like exactly as I was explaining. So here, with this osteophyte, should I do varus osteotomy and bring it inside? Or should I do valgus osteotomy and improve the symptoms of the patient and the function and the patient live happily? This is where our rationale came from, and this is a hip arthrography because the hip arthrography is much more sensitive than MRI. Why? Because it is dynamic and it shows us where the acetabulum and the labrum and the surface area of the acetabular cartilage and femoral head cartilage, because this is where the gold is. This is where the money is. This is what we need to really see. If you look at this X-ray, it's a very deformed head. and it is subluxed, as some people claim. But if you look at the arthrography, the head is well covered and very smooth. So actually, this patient need no surgery, no treatment. This is another example about hinge abduction. So hip arthrography is crucial here to decide where is the direction of the osteotomy that you need to do and how to do it and how to rotate. And as I explained, we published this paper and with the very long-term follow-up, 15 years follow-up, and the surgical technique is explained. And as I told you, we improve the patient symptoms. The patient live here happily for 20, 30, 40, 50 years. If at some point he or she may need total hip, like we saw in natural history cases, these patients do not get arthritic changes, I mean major real arthritic changes in the hip before age of 50. So if you correct the limb length discrepancy and the symptoms of the patient, like here, 5 years follow-up, as you see here, and this is at the time of hardware removal, the hip look very good and very smooth. We have so many cases, as I told you before, so with long follow-up, enough to prove our theory that valgus osteotomy and correction of the deformity is the key for such cases, and that's how we should treat these patients. We need to treat patients, we need to correct the symptoms of these patients to live their life, correct, not to do another surgery that will not correct the problem nor improve the symptoms of the patient. Thank you very much, and I hope this talk will help you in making the right decision for your patients. Thank you.